Madam. Madam, you are mute, madam.
Good evening. I'm so happy to be here because this is our important day where we are going to launch officially the website of Pedicon 2025, which is being conducted in Trivandrum this year on November 14, 15, and 16. And this is actually our, after the installation of the new office bearers, this is the first Zoom meeting or the first program that is being conducted. So I am so happy that Dr. Bindusha and Dr. Chinchilu is presenting on the OSCE on pediatric, the PG club. And so this will be a great program. I also, so for there are our state leaders are here. Dr. Rias is here, Dr. Gobi Mohan is here, and Dr. Mohandas, the state coordinator, is there. So Dr. Jose is there, and so everyone we know, and Dr. Purushothaman sir, as usual, he is always here for all our PG program, not only PG program, all webinars, everywhere he is there, and he will be actively participating. And so I give a warm welcome to all of you. And today the academic program will be very good. In addition, we have the important program of hosting a website, as well as we have the state program of the expressions is also officially launched today. So I'm giving a warm welcome to each and every one of you. Dr. Shanavas also has joined, and welcome to Dr. Shanavas also. So welcome to all of you, and we can continue with the program. Thank you.
Okay, thank you, madam. Thank you very much, madam. And now I invite the State President, Dr. Riaz, to deliver the presidential address as well as the release of the logo.
Respected President of IAP Trivandrum, my most respected teachers in the forum, and my dear friends. I acknowledge the presence of Jose sir, and I think the President-elect Dr. Nandakumar will also join. And today is a very important day for all of us, because after a long gap of 10 years, Pedicon is reaching back to Trivandrum, and the Trivandrum team is doing their best to make it the best ever Pedicon happened in the recent times. And they are ready with the website, and they will be opening the registrations also from today. And they were actually, usually the early bird offer ends on January 31st, but Kalpana madam was very particular that we should extend the early bird till at least February 15th. So it is also decided like that. And we will very soon we will see the website. And also another important event which is happening today is launch, or I should say it is a relaunch of a section of our website. So this will be actually a new website where we can discuss cases. So for the last 1 year continuously, our Jaykumar sir was posting clinical cases in that particular section, but contributions from all of us were very scarce. And now we all are committed to it. And so today we are relaunching. And during the relaunch, I was searching for a title for this one, and Sulfisa gave me one title, which is Expressions. So Expressions is a meeting place for pediatric clinical experiences. So this will be a very interesting section or a website which Dr. Praveen will explain, and Jaykumar sir also will be telling about that. And I also congratulate the IAP Trivandrum team, especially Dr. Lakshmi Raj and Dr. Priya for making all these, arranging all these OSCEs, and the faculty, Dr. Chinchilu and Dr. Bindusha. So we will have a very good learning session. All the best. Thank you.
So the flyer release also should be done.
Yes, yes. Shall I tell that please? So I am declaring that the flyer is being released, and you can show the flyer with all your permission and best wishes. Praveen is sharing?
Praveen is sharing.
Okay. So I think Praveen is today at Idiki. Okay, okay. Okay.
Thank you, Praveen, and
Do you want to tell anything? The Srijit or Kalpana madam, you want to tell anything in the website, about the website or
Srijit, please talk. Srijit.
About the website talk, this website is exclusively designed by our Praveen only, and actually we will come with the more features and we'll update this website of the Pedicon website. Through the website, we can actually make a early bird registration for 5,000 from today onwards. So we will start our early bird registrations right now, and it can be done till the January, the end of this month. So please.
February 15th.
February,
Yes,
February 15th.
As we can, as Madam corrected, as we can early bird registration till February 15th. So 1 month period. So I request all the postgraduates as well as other members in the platform to register today itself. Thank you. So I invite Dr. Gobi Mohan sir, the state secretary of IAP, to deliver the address. Say a few words. Dr. Gobi Mohan sir.
Yeah. Honorable President Riaz, Kalpana madam, all the dignitaries, my seniors. Am I audible?
Yes, yes.
Am I audible?
Yes, yes.
All the dignitaries and friends and PGs. I'm very happy that we are launching the expression wherein we can put in a case presentations. So Jaykumar sir has been doing an excellent job, and we should promote this by posting the cases and going through it and sending our comments. And I'm also happy that the flyers of IAP Trivandrum Pedicon is going to be released today. Now they have kickstarted their campaign, and I wish the Pedicon a great success. Thank you. Jai Hind and Jai.
Thank you, sir. Thank you, sir. So now we move on to the next program, that is the relaunch of Expression website. To brief us on this website, I invite Dr. Praveen K.S., the webmaster of IAP Kerala. Praveen.
Yeah, thank you, Srijit. Actually, this was made last year at the request of our dear Jaykumar sir. Sir was actually posting cases for the last 365 days, but sir stopped posting on December 31st, 2024. Actually, sir's commitment inspired us to take this to the next level. Now we have relaunching the website, and actually many were reluctant to post in this website. I think many were thinking that this needs a formatting, formal formatting, less similar to that required for a journal. But this is not very formal like a journal. Everyone can post the cases, but not only the cases. I think everyone can share things like unusual occurrences of any cases in any part of the state can be posted in this forum. One major change we are making this year is this is actually previously it was an open platform accessible to anyone, but now we are changing this to a members only platform. So anyone who wish to see the cases posted or who wish to post it need to have a login for this. can be easily get the login by sending a mail to our email expressions.iap@gmail.com. I will share the email in the group as well as in this chat box with your name only. And I thank the State President, Secretary, and Treasurer for bringing this into the new version. And also a special thanks to Sulfi sir for giving this a very beautiful name. And Jayakumar sir actually needs a big round of applause for the huge task of posting cases every day for the last 365 days. So I will also send a mail to all IAP Kerala members with the instructions how to use the website. Thank you, Srijit. Then I will share the screen showing the website. Is it visible now?
Yes, it's Praveen.
Website actually we have, even though we have changed the web URL and all everything, the old cases posted by Jayakumar sir is still available in the new platform, that is expressions.iapkerala.org. Here we can see. Today it is open platform. Tomorrow onwards we will change it to only login members only access site.
Yes. I should also add that when we post cases, make sure that we don't reveal names or any identity features, because we should be protecting patient privacy also.
Thank you.
So thank you, Praveen. So now I thankfully invite Dr. Jayakumar sir, so who has written maximum number of cases in this platform, to say a few words. Jayakumar sir.
Sir, unmute you. Sir, muted ആണ്.
Hello, dear all.
കേൾക്കാം.
At the outset, I would like to thank the At the outset, I would like to thank the previous president, Dr. Simmi, Dr. Krishna Mohan, and Dr. Praveen for giving me the opportunity to post a case every day. 365 cases I posted, and really thankful to all of you. At the same time, thankful to Dr. Riaz and also the Gopi Mohan right now for continuing this program along with the Dr. Praveen. Unfortunately, I don't think that so many people saw our website. And in fact, we could see how many people are seeing, but of late they didn't allow to see how many people are seeing that. Even people from outside Kerala and outside India are viewing this program. But my request is that all should post cases every day and should be a wide.
Sir, you are not audible, sir.
Sir, train
Travel ചെയ്യുന്നുണ്ടോ?
So how to make this program a little more like interactive, like
Madam, actually this platform will be interactive. Once you
difficult to get cases because interested, because all should, if all, yeah.
സാറിന്റെ കണക്ഷൻ പോയി സാറേ, കിട്ടുന്നില്ല. Okay, we'll continue, Srijit.
Okay. So thank you. Actually, there is connection issue. So thank you, Jayakumar sir, for your address. And actually, we will move on to our next program. And this is the OSCE session. And Mohandas sir is the state coordinator of this PG program, but sir is unable to talk right now. He's not in the platform. So I request Dr. Priya Srinivasan, madam, the South Zone coordinator of PG Club, to give the introduction as well as to introduce the speakers.
Thank you, Dr. Srijit. Now we have the OSCE program, the first of its kind. Can you hear me?
yes.
Yes.
So it is the first of its kind in this PG club. Usually we were having case discussions only, and now we have started this OSCE discussions. And regarding the faculty, they are my own colleagues, Bindusha. We all know Bindusha. She is the professor of pediatrics at Government Medical College Trivandrum. And she has done her training in asthma and allergy from CMC Vellore. And she is conducting the asthma clinic, asthma and allergy clinic of SAT Hospital Trivandrum. And regarding Dr. Chinchilu, Chinchilu is my own colleague. He is assistant professor of pediatrics at Government Medical College Trivandrum, and he has got special interest in bronchoscopy procedures, and he is presently doing some bronchoscopy procedures along with Dr. Bindusha. So, and before going on to the OSCE session, I would like to invite Dr. Lakshmi to brief regarding how we are conducting this OSCE program, because it is the first time that we are doing it. Over to Lakshmi. Please unmute Lakshmi. Lakshmi, you're not audible.
ശ്രീജിത്ത്, ലക്ഷ്മി ഒന്ന് അൺമ്യൂട്ട് ചെയ്ത് കൊടുക്കണം. പ്രസ് ചെയ്താലേ അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റത്തുള്ളൂ.
Unmuted, already unmuted.
And we can see Mohandas sir also. Mohandas sir is here.
Sir,
it's a difficult technical.
I am here. Okay, just please continue the program.
Okay, sir. Thank you. ലക്ഷ്മിക്ക് കണക്ഷൻ പ്രോബ്ലം എല്ലാം ഉണ്ടോ?
Am I audible now, madam?
Yes. Please continue.
Please continue.
Okay. So we have planned we are planning to conduct 6 OSCE questions today. So these first 3 questions will be discussed by Bindusha madam, and the next 3 questions by Chinchilu sir. So we have assigned 6 PGs from SAT, 1 PG for each OSCE question. So after displaying the question, we will be giving 1 minute, and all the PGs who are participating in this program, they can think about the answer. And after 1 minute, the PG who is assigned for the question will tell the answer, and following that, the discussion will be done by the faculty. So we plan to complete 1 OSCE within 10 minutes so that we can complete the program within 1 hour. So I think we shall move on to the OSCE. I invite Bindusha madam to share the screen and start the discussion.
Thank you, Dr. Lakshmi. I also would like to thank all the office bearers of Kerala IAP, Dr. Riaz, Dr. Gopi Mohan, Trivandrum IAP, Kalpana Madam, Srijit and Karthika, and also the PG Club coordinators led by Mohandas sir, Priya, and also Dr. Lakshmi. I would like to share, I am sharing my screen. Can you see my screen?
Yes. Full screen.
Okay.
Full screen, please. Okay, thank you.
Now, I will be discussing 3 questions. The first 2 questions will be based on this scenario. I'm just reading out the question, and after that, I'll be giving the question proper, and they can answer. Okay. This is a 10-year-old girl with history of cough and wheezing for the past 2 years. There is a history of eczema, mainly in the face and limbs, in the infancy and the early childhood. She also has history of sneezing and nasal itching on most days. Now she is having cough on 5 to 6 days a week, on most days in a week, and night awakenings due to wheezing 2 to 3 times a week. This is the scenario. This is a 10-year-old girl with cough, wheezing, now symptomatic on almost all days, with night awakenings due to wheezing around 2 to 3 times a week. Now the first question is, I'm going to give a spirometry. Dr. Arya has to interpret this spirometry, and also you need to give me the diagnosis from the spirometry. Okay, this is your question.
Yes, madam. Am I audible, madam?
Okay. You can wait for, you can take a minute to analyze the spirometry and then start speaking.
Can I ask a doubt? Bindusha,
Yes.
can the other PGs post the answer in the chat box?
Yes, they can actually they can post, but they can. I think it will be better if they post it directly to me. Otherwise, it may interfere with.
Okay. Okay.
Am I
So
audible?
anyone interested can post directly to Dr. Bindusha.
Adi, you can start answering.
Yes, madam. This represents a flow volume loop. We are able to see the pre-bronchodilator and post-bronchodilator response. In the flow volume loop, the pre-bronchodilator response, that is a curve which is smaller in volume. The flow, that is the upper curve represents the expiration and the lower one represents the inspiration part. We can see that there is more residual volume and reduced inspiratory volumes. So the volume will be shifted towards the left side, the flow volume loop. And the FEV1 by FEC, here the predicted percentage is 65. It is less than 70%. So this spirometry represents a case of bronchial asthma.
Okay, what is the finding that you expect in bronchial asthma? The scenario is like asthma only, right?
Yes, ma'am.
So what are the findings that you expect in the spirometry in a child with bronchial asthma?
The flow volume loop will shift towards the left side, madam. Towards the left side. It represents that the residual volume will be increased. The functional residual capacity will be increased. The inspiratory volume will be reduced.
Okay, actually the residual volume, functional residual capacity, these values cannot be seen in a spirometry.
Okay.
You can only look at the forced vital capacity.
Forced vital capacity and forced expiratory volume at the first second and the consecutive seconds.
Okay, can you tell me the parameter which determines, which actually tells us that there is expiratory obstruction?
FEV1 by FEC, madam.
Okay, very good. FEV1 by FEC is the one which tells us whether there is an expiratory obstruction or not.
Yes, ma'am.
And in asthma, what is the peculiarity of this airflow limitation or obstruction?
It is usually less than 70%, madam, in case of asthma.
Okay, and
a post-bronchodilator response will be more than 12%.
Okay, and there should be an increase with the after bronchodilator. Okay, first let me explain this. Okay, now we will. You can see that there are two graphs, and I have removed the values. Can you see my pointer? Can you see my pointer?
Yes, ma'am.
Okay. What is the name of the first graph that I am showing? This is the flow volume loop. It has an expiratory part which is triangular in shape and an inspiratory part which is semicircular in shape. You can see two graphs. The blue one is pre-bronchodilator and the red one is post-bronchodilator. Okay. And the second graph that is towards the left side is the volume time plot. Okay. As we said earlier, in asthma, there will be expiratory airflow limitation. So the most important parameter that you want to look for in case of asthma is the ratio between the FEV1 and FVC. Here you can see the highermost point or the lateralmost point here. This is the FVC, forced vital capacity. And forced vital capacity is the volume of air that comes out during the full expiratory manner. We will ask the patient to take a deep inspiration and we'll ask him to do a forced expiratory maneuver. That is to breathe out as fast and as hard as he can, so that you can get a forced vital capacity. So this is the forced vital capacity. And the volume of the air that comes out in the first second of expiration, that is the FEV1. You can see this one. Here you can see that in the first second, only around 2 liters of the air has come out. And in the 6 seconds, it has breathed out for more than 7 seconds. And by around the end of expiration, around 4 liters, it's just below 4 liters. 4 liters of air has come. So you can, from the graph itself, you can see that the FEV1 by FVC ratio is less. FEV1 by FVC ratio less than 80% should be considered as airflow obstruction. Okay. And another thing that we need to look for in this graph is that whether the patient has breathed out fully. Patient has to breathe out for minimum of 6 seconds. If the patient is not breathing out for 6 seconds, he may not be completely expelling the air inside the lungs. In case of children, you can even accept this graph if he has breathed out for 4 seconds. But if the patient is breathing out for 1 or 2 seconds, then what will happen? Only this much of air will be coming out, and you will erroneously think that the patient is not having airflow obstruction. Okay, so that is what you look for in the flow volume time plot. Now coming to the second graph, that is the flow volume loop. Here you can see what is the highermost point of this graph, which I am showing here. Here flow is in the y-axis and volume is in the x-axis. So what is the highermost point of the flow? This is the peak expiratory flow. So the highermost point is peak expiratory flow. You can see that the blue peak expiratory flow is a little lower than the red peak expiratory flow. That you can very well see here. Okay. And this is the lateralmost point is the forced vital capacity. You can see both the pre-bronchodilator and post-bronchodilator expiratory vital capacity. Okay. Here you can see this is the peak expiratory flow. And this is the forced vital capacity, and the slope between these two, this one is the forced expiratory flow between 25 to 75. Okay, these are the things that you have to look for. So when now coming to the values, the values are actually derived from the graph. As we said, since the patient has a history which is suggestive of asthma, or even in a patient where we don't suspect asthma, the first parameter that you will look for is the FEV1 by FVC. Okay. There are different parameters which are entered here. You can see FVC, you can see FEV1, FEV1 by FVC, then PEF and forced expiratory flow 25 to 75. All these are important, but the major parameter or the most important parameter is the FEV1 by FVC, and that should be the one which should be first looked for. And when you look at the columns, the first column is the predicted values. What is this patient's predicted values in all these parameters? That depends upon the patient's age, gender, then height, weight, ethnicity. Depending upon these, the machine will give you the predicted values. And then in most of the machines, there will be a lower limit of normal also, but in some machines, it may not be there. Then you will have pre-bronchodilator values and post-bronchodilator values. Under the pre-bronchodilator values, you can see the actual values and also the percentage of predicted. Under the post-bronchodilator also, you can see the actual and percentage of predicted. Okay. Understood?
Yes, ma'am.
Okay. Now, as we said, you will look for the ratio between the FEV1 by FVC. So here, what is the FEV1 by FVC ratio?
0.561.
It is 0.56. That means 56%.
56%.
It is definitely less than 80%. So that tells you that there is some expiratory airflow limitation. Okay. Now, once there is expiratory airflow limitation, you want to do two things. You want to grade the airflow limitation, and also you want to know whether this airflow limitation is reversible or not. How will you know whether it is reversible? You will give bronchodilator. You will nebulize the patient or give a salbutamol MDI. Give him 200 to 400 micrograms of salbutamol MDI, and then repeat the spirometry after around 15 minutes. Then, which is the parameter in which you look for reversibility?
Peak expiratory.
No, you will look for reversibility in FEV1. Reversibility only in FEV1 for diagnosis. All these parameters may be reversible, but diagnosis depends upon FEV1 reversibility. As we said, FEV1 is the one, the ratio between FEV1 by FVC is the one which tells us whether there is bronchial obstruction or not. So if there is a response to your bronchodilator, FEV1 should increase. You will see whether there is an increase in the absolute value of FEV1. Here you can see that FEV1 pre-bronchodilator was 2.2 and it increased to 2.85. So there is an increase of around 650 ml in this patient. Right. Okay. Now we will also see whether there is an increase in the percentage. Here the percentage has increased from 54% to the 70%. There is a 16% increase in the FEV1 percentage. So it had for us to make a diagnosis of asthma, there should be at least 12% increase. The higher the increase, more confident is the diagnosis of asthma. Okay. This 29% does not have any significance. Why? Because this 29% is the machine expressing what is 16% based on 54%. That does not have any importance. You need to actually subtract 54 from 70 to see the percentage change in the FEV1. Okay. So from this graph, you can see that the patient is having expiratory airflow obstruction and there is reversibility. So you can make a diagnosis of asthma. Right. As we said earlier, because in the first table, you were seeing a lot of values, but you actually need not look at all these values. Only those values which I have not deleted are the ones you need to look at. As we said, first we will look at the FE1 by FVC ratio. Then you will see compare the pre and post bronchodilator absolute values of FEV1 and the percentage values of FEV1. Okay, that will be sufficient in most of the cases. Here we can also see that once you find out that there is obstruction, you can also grade the obstruction. The grading of obstruction is also by looking at the FEV1 percentage. Any value above 80% is considered normal, 70 to 79 is mild, 60 to 69 is moderate. Actually, you need not actually study the grading. The only thing that you need to study is that how to look for airway obstruction and how to look for reversibility. Okay. So this we have described. So the answer is the patient is having moderately severe expiratory obstruction with post-bronchodilator reversibility. Or it can otherwise be called as bronchodilator response. So this is suggestive of bronchial asthma. Clear? Do you have any doubt, Arya?
Madam, with respect to the percentages that has been mentioned, madam, in some textbooks they have mentioned less than 70% also. Is there any?
Yeah. Actually, it may vary. In children, actually, the normal value is more than 90%. Okay. The normal FEV1 by FVC ratio in children is more than 90%. So any value less than 80%, so you can take it as obstruction. In adults, some of the books may say lower values, but in children, usually 80 is taken as the cutoff point because in children, the normal FEV1 by FVC ratio is higher than in the adults. That is usually around 90%. Okay.
Thank you, ma'am.
Can we move on to the second question if there is no doubt regarding this? Okay. Now?
Actually, this will be a little difficult for all of you to understand. So if you want to review or revise this, there is a YouTube link. This is being recorded.
Okay, thank you, please. Now, coming to the second part of the question, this is the same scenario. The second question is, which GNR step will you start this patient on? And what is MART and AIR in the management of bronchial asthma as recommended by GINA? And which are the drugs that can be used as MART and AIR? And what is the maximum daily dose of these drugs? Abhishek can answer. Abhishek,
nice. Am I audible, madam?
Yes.
Yes, ma'am. Since this child has frequent symptoms with night awakenings, I would like to start with step 3 as per GINA guidelines, which is a low-dose inhaled corticosteroids with long-acting beta agonist, or other rationale is we can use a very low dose MART therapy. So what is MART? MART is maintenance and reliever therapy, and AIR is, I think, anti-inflammatory rescuer.
Anti-inflammatory reliever.
Reliever, as per GINA. So as per MART, we use budesonide plus formoterol as maintenance and reliever therapy. And the maximum daily dosage of these drugs are like 8 puffs per day. If it is 100 bar 6.
100 bar 6, you can use up to 6. Very good. Now, there needs to be some clarifications only. Okay, what are the steps in the management? The steps in the management will depend upon the frequency of symptoms. If the symptoms are less than 2 days a week, then you go for step 1 management. And the step 1 management is to take low dose inhaled corticosteroids when the SABA is taken, when short-acting beta agonist is taken. So that is the step 1 management. And the evidence for the management is the one which is given in red letters. It has an evidence B. And step 2 management you give for a patient who has symptoms on 2 to 5 days a week, but not on most days, and no night awakenings. For that patient, you give low-dose inhaled corticosteroids as the maintenance drug and short-acting beta agonist as the reliever drug. This is the treatment steps for children up to 11 years of age. It's not for the adults or adolescents. In adults and adolescents, there are 2 tracks of management at all. Now, for our child, the child was 10 years. So, this will be the treatment for that child. Okay, so here the child was having symptoms on almost all days, and the child also had night awakenings on once or more per week. So the child has to go out for either a step 3 management or a step 4 management. What is the thing which determines where you go for step 3 or step 4? That depends upon your lung functions. Okay. If the patient has low lung functions, you go for step 4 management. And if the patient has normal lung functions, you go for step 3 management. Okay. Go to the step 3 management. In step 3 management, there are 3 options. You can use either low-dose ICS plus LABA, low-dose inhaled corticosteroids with a long-acting beta agonist like salmeterol, or medium-dose inhaled corticosteroids with short-acting beta agonist as a reliever, or a very low-dose MART. But these are the 3 options. And the evidence for option low-dose ICS plus LABA and medium-dose ICS with SABA reliever is A. But for very low-dose MART, you have a evidence of B. But nowadays, a lot of people are going for MART even for a 6 to 11-year-old child if the patient has very frequent exacerbations. Okay. Then for step 4 management is for the same patient, if the patient is having a lower lung function, you use a little more of steroids. There are 2 options only. You can use either a medium dose ICS plus LABA or a low dose MART. So these are the options available. Here, depending upon the lung function, since our patient is having a low lung functions, you may start the patient even on step 4. Okay. Now, what is low dose MART? And what is very low dose MART?
Based on the dosing, I think very low dose, OD, it can be given OD 100 bar 6, and low dose we give BD as BD.
Okay, up to 100 microgram of budesonide plus 6 micrograms of formoterol is considered as a very low dose. And if the daily dose is 200, then it is considered as a low dose MART. Okay. This is the same thing that we explained. Okay, so MART is maintenance and reliever therapy. Maintenance and reliever therapy is a combination of steroids, inhaled corticosteroids, low dose inhaled corticosteroids Either budesonide or beclomethasone can be used, but beclomethasone is preferred in the age group above 18 years. Usually in children, we use only budesonide plus formoterol. And very low dose is up to 100 microgram steroids plus 6 microgram formoterol. It may be used as 100/6 once daily or 50 plus 3 BED. Usually only it's very difficult to procure 50 micrograms inhaled corticosteroids with 3 micrograms of formoterol. So the usual drug that we use is 100 microgram budesonide plus 6 microgram of formoterol. And if you're using it once a day, it is known as very low dose MART. And if you're using it twice a day, it is known as low dose MART. In MART, when the patient is having symptoms, you will use the same drug that they are using daily as a reliever. So what is the difference from the anti-inflammatory reliever therapy and this MART? In anti-inflammatory reliever therapy, actually, there is no maintenance therapy. The patient is using, for a reliever therapy, the patient is using a combination of low-dose inhaled corticosteroids with a rapidly acting bronchodilator, so that the patient can use either budesonide formoterol combination as a reliever, or the patient may even use budesonide with short-acting beta agonist as a reliever. If you're using budesonide and short-acting beta agonist as a reliever, you're supposed to take short-acting beta agonist first and then take budesonide. And inhaled corticosteroids has to be taken whenever patient requires salbutamol or short-acting beta agonist. That is anti-inflammatory reliever therapy. Now coming to the maximum dose of drugs that can be used in a day in a 10-year-old child. In a 10-year-old child, you can use only up to 8 inhalations of 6 micrograms of formoterol. If you're using a formoterol, you're using a drug which contains formoterol of 6 micrograms, you can take only up to maximum of 8 inhalations in a day. Okay. If you're using a drug which contains 3 micrograms of formoterol, you can use double dose. In adults, the maximum dose that can be used in a day is 12 inhalations. And this, I think I have already explained. The anti-inflammatory reliever therapy is a combination of either budesonide formoterol or ICS whenever salbutamol is taken. Thank you, Abhishek.
Welcome.
Now we will go to the next question.
Bindusha, about the cutoff of 8 and 12, is it adult or is it in the adolescent group also can we use 12 numbers?
Yes. For adolescents and adults, it's recommended to use up to 12. For children up to 11 years, they have given a cutoff point of 8. Okay, next question will be answered by Dr. Shilpa. Okay, this is the question. What is this device used for? You can see a device and what is the principle behind the use of this device. You can also tell me 2 contraindications for its use. Shilpa? Shilpa is not there?
Shilpa Vijayan. If Shilpa is not there, Arya or Abhishek can answer.
I think Sumaya has answered in the chat. Sumaya can also answer.
Ma'am, this device is Acapella.
Yes.
which can be used for chest physiotherapy. The principle behind the use is it is vibration actually. It gives the vibration from the machine will be transferred to inside the lungs, and the whatever secretions can be just expectorated, ma'am. So contraindication, one contraindication I know is air leak, ma'am. So second contraindication I'm not aware of, ma'am.
Okay, thank you, Samaya. That is a very good answer. Okay, so the device, it's written there. The name is Acapella. Okay, Acapella is a device which is used as for chest physiotherapy, especially for children with bronchitis, either cystic fibrosis or non-cystic fibrosis bronchitis. It is used to mobilize secretion from the peripheral airways into the central airways so that it can be expectorated. Okay, so actually my slide is now okay. So this is used for airway clearance, and also since this is the principle behind this Acapella is that it provides a PEEP, and this PEEP is vibratory or oscillatory PEEP. So what happens is here the patient it has an one-way valve here. So that when the patient is inspiring, this is the mouthpiece which the patient will keep in the mouth and will inspire through the device. So when the patient is inspiring, there is no resistance and the patient will be able to inspire freely. Then when the patient is expiring, what will happen is this one-way valve will close and the air has to move out through here. Okay, and here there is some magnet and a metal bar device, so mechanism, so that it will actually, the patient has to generate some resistance, has to breathe against some resistance. Then only this will open up. So that will actually lead on to generation of a PEEP, and it has a rocker arm which will vibrate, and there will be a formation of oscillatory. Then some oscillations also. It has around 10, produces oscillations at a rate of around 11 to 15 hertz. So that there will be generation of oscillatory PEEP. That is the mechanism of action of this device. So what will happen is that since there is PEEP, what will happen? This PEEP will be beneficial in two ways. The PEEP will help in splitting up on the airways. Whenever you give PEEP, there will be some splitting up of the airways. And also this PEEP will encourage airflow behind the secretions. So since there is a pressure, the air may be able to enter behind the secretions. And when it is combined with the oscillations, it will produce some vibrations in the airway wall and mobilize the secretions to the central airways. And it can be very well easily expectorated. So this is a device which is used for airway clearance, especially in the case of children with bronchitis. The contraindications, as Sumaya said, air leak syndrome is a contraindication. Then any child who is hemodynamically unstable, any child with cardiovascular diseases, undrained empyema, lung abscess, active hemoptysis, sinusitis, medial infections, all those conditions where increase in pressure may produce problems are contraindications for the same. There are other devices also which will work on the same principle. It's available as flutter, PP, then TheraBubble, where the patient can actually exhale through water which is there in a bottle. All these things can actually be used for airway clearance. Now I think we have completed all the 3 questions. Thank you.
Thank you, ma'am.
Any age cutoff for this device?
Actually, these devices, especially this flutter, Acapella and all, it can be used only by older children. That means after around 5 to 6 years of age. So that because the patient actually has to take a deep breath and then has to actively exhale through this device. So the small kids may not be able to use that device. But for smaller children, the TheraBubble or an indigenous mechanism where we can keep a tube of around 1 centimeter diameter under a water column of around 10 centimeters, that can be used even for a small kid. Well, if you add some liquid detergent or even some coloring agents, it may produce very attractive bubbles. So that's even smaller children, around 3-4 years may be able to use the Therabubble. The other devices only after 5 to 6 years of age, they'll be able to do. If there is any doubt regarding this, I can discuss. Otherwise, we will move on to Dr. Chinchilu.
Maybe we can move on, I think. Discussion at the end will be better.
Okay, sir. Am I audible, sir?
Yes.
Yes, okay. So I'll share my screen. Okay. So good evening, everyone. So after having been enlightened on asthma, acapella and all, we will be moving to the next session. So here I would like to discuss 3 case scenarios. So these 3 case scenarios have one thing in common. All these case scenarios, the child will be presenting with chronic cough. So as you all know, cough is the most common complaint for which the parents take their child to the OPD. It's also most distressing for the parents. So it will be affecting their quality of life, their sleep pattern, and also it will contribute to school absenteeism and also their normal activity at school. So, a normal URA, a normal upper respiratory infection, the cough will resolve by about 1 to 3 weeks. So, any cough persisting beyond 4 weeks, you can call it as a chronic cough. So, I'll be discussing some case scenarios which will present as a chronic cough, both dry as well as wet cough. So, the purpose of my discussion will be, sir, if you could consider these conditions also in the differential diagnosis of your children presenting with chronic cough beyond asthma and tuberculosis. So the conditions which I am going to discuss may not be that common when you compare it with asthma and tuberculosis, but still most of the cases are underdiagnosed because of lack of awareness as well as the lack of facilities for making a proper diagnosis. So with that, we will move on to the first question. So I think Manu can answer the first question. So a 10-year-old female child is brought to the OPD with history of on and off fever and persistent increasing cough with post-acid vomiting for the past 10 days. Mother also gives a history of headache and myalgia. The child had a maculopapular rash and oral mucositis few days back, which now resolved. Mother also noticed that the child always prefers to lie on her left side. So on examination, it's a well-looking child with SpO2 of 93% on room air. That is, the child is having a mild desaturation. Respiratory rate is 40. And when comparing, while seeing the age of the child, you can see that the child is tachypneic. Mild retractions are there. Scattered crabs can be heard on auscultation, and expiratory wheeze is also present. Blood investigations were normal except for mildly increased inflammatory markers. So this is the chest X-ray. You can just go through. If you want, I will be displaying it once again. So if it's not clear, I am sorry. This is the chest X-ray. And the question is, what's the most probable diagnosis you will entertain and give one close differential diagnosis? How can you confirm your diagnosis and how will you manage this child? So Manu can answer. You can take 1 minute to think, and after 1 minute, you can start answering. Manu, are you there?
Yes, sir.
Okay. You can take your time, and after that, you can answer.
Do you want to see the X-ray?
Okay, I will display it, madam.
atypical pneumonia with the left-sided pleural effusion, probably Mycoplasma pneumonia, since there is history, there is a rash with oral mucositis, and there's a well-looking child.
Okay, okay, Manu. Yes, that's the correct answer. It's an atypical pneumonia. Can you answer the second part?
There will be IgM PCR positive for Mycoplasma.
Okay, okay. Any other test which can be used as a screening test, which is not specific?
Cold agglutination
Okay,
test.
very good, very good. Then the third part, last part.
First line drug is macrolide, oral azithromycin, 10 mg per kg per dose for 3.
Okay, okay, very good. Okay, Manu, very good. Thank you. So we'll be having a brief discussion on the case. So this child was a 10-year-old child. The child was having headache, myalgia, and respiratory complaints. It's a well-looking child, and the SpO2 was 93%, desaturated with some chest findings also. So in this X-ray, you can see that atypical pneumonia is basically seen in older children, usually above 5 years. The most common age group of atypical pneumonia is 5 to 15 years. So there are many differences from typical pneumonia, which is usually caused by pneumococci and all. There are certain differences that we'll be discussing. So in this X-ray, you can see that there are bilateral findings, bilateral infiltrates are there. But in the left side, left lower zone, you can see that there are both homogeneous and non-homogeneous opacities. Homogeneous opacities are usually seen in case of pleural effusion. Both the cardiophrenic and the costophrenic angles are obliterated, and you can see some homogeneous opacities towards the cardiophrenic and costophrenic angles. So there is effusion. And also above that, and also on the opposite side, you can see some non-specific findings. You can see non-homogeneous opacities, which represents consolidation. And these were the questions, and we will be briefly discussing the case. So the answer to the first question is an atypical pneumonia, mainly Mycoplasma is the causative organism. So since the child is not sick, like when you compare with a typical pneumonia where the child is toxic and sick, in this case the child will not be that sick, so the child will be walking around in the wards. So we call it as a walking pneumonia. But despite of that, there will be more and more signs you can elicit while examining the child, and the X-ray will be showing gross findings. As we saw in the previous X-ray, you can see consolidation, you can see effusion. And first, when you see the X-ray, you will think that the child is very sick. But when you compare the X-ray and the child, you will see that the child is disproportionately, the child is not having much of symptoms. So that is what is called a Mycoplasma pneumonia or atypical pneumonia or walking. So one of close differential diagnosis is always a viral pneumonia. Viral pneumonia will also be presenting like this. So you can differentiate it by properly taking the history. In viral pneumonia, there will be coryza and predominant GI symptoms. The child will be having abdominal pain. Sometimes the child will be having recurrent vomiting, and the child may have a diarrhea. But those GI symptoms are not common in Mycoplasma pneumonia. And also, you can analyze the CBC. In the CBC, in Mycoplasma pneumonia, it's almost normal CBC. You will get a normal CBC. Whereas if it's a viral infection, as you know, the total count can be normal or low. And the differential count, the child will be having a strong lymphocyte predominance. And also platelet can be low or normal. Whereas in a Mycoplasma pneumonia, most of the time you see a normal CBC. So by that you can differentiate it from viral pneumonia. So what are the atypicalities? You call it atypical pneumonia. Mycoplasma pneumonia, you call it an atypical pneumonia. What are the atypicalities you expect? Manu, can you tell the atypicalities which you expect in an atypical pneumonia when you compare with the normal pneumonia, typical pneumonia caused by Staph aureus or pneumococci?
There will be predominantly more signs.
The signs will be very good. The signs will be more than the symptoms. The child may not be having much of symptoms, but the signs will be more. Whereas in a typical pneumococcal pneumonia, the child will be having much of symptoms. Then organism is atypical. There you have pneumococci or staphylococci as the predominant organism. Here you are having a unique organism, that is Mycoplasma. Mycoplasma is different from other bacteria in that they are having very small size, which is comparable to viruses. They are not having a cell wall unlike other bacteria. Since they are not having a cell wall, under any condition, they will not be forming capsules. They will be never form capsules. All the other organisms under some stressful conditions, they will be forming capsules over their cell wall. Since Mycoplasma is not having a cell wall, they will not be forming any capsules. So that is a major atypicality. The age of presentation, as we discussed previously, a typical pneumonia is a major killer disease in less than 5 years, whereas Mycoplasma pneumonia usually seen 5 to 15 years of age group. Under 5 children also now Mycoplasma is reported more and more, but the major age group is 5 to 15 years. That is another atypicality. Then the presentation, as we discussed, the child will be having more signs than symptoms. The child will not be toxic and sick. And basically, Mycoplasma predominantly infects the interstitial rather than the alveoli, which you see in pneumococcal pneumonia, so that they can go for an early desaturation. Even if the child is not sick, even if the X-ray is not showing much of signs, when you check the SpO2, it will be only 91 or 92. That is, since the air exchange area, the interstitium is affected, they can go for early desaturation, unlike a typical pneumonia. Also, they will be having, since the airway is also inflamed, unlike the typical pneumococcal pneumonia, Mycoplasma is having an affinity for the airway also. Since the airway is inflamed, they will be having V's also. That's why we told that viral pneumonia closely mimics Mycoplasma pneumonia. In both viral pneumonia and in Mycoplasma pneumonia, you can auscultate V's. So V's is a predominant find. The difference in presentation is that the typical pneumonia, pneumococcal pneumonia, will be confined to your chest alone. In Mycoplasma pneumonia, you can have predominant extrapulmonary manifestations. In almost 1/4 of the children, you can see extrapulmonary manifestations, mainly skin manifestations. You may get a maculopapular rash, urticarial type of lesions. You can get mucositis resembling Stevens-Johnson syndrome. You can get arthralgias. You can get predominant findings in your ear, external otitis media, external otitis, and typical bullous lesions on your tympanic membrane, which is referred to as bullous myringitis. And also, there can be during the second, all these extrapulmonary manifestations usually occur towards the end of the first week or the second week. By the second or third week, some children, maybe less than 10% of the children, may also have drop in their hemoglobin, which is secondary to a cold agglutinin hemolytic anemia. All these are the difference in the presentation. And another atypicality is the drug which you choose. We usually treat a respiratory infection with amoxicillin as the first line drug. Here, since the Mycoplasma is not having a cell wall, none of your cell wall synthesis inhibitors such as your cephalosporins or your penicillins are not going to act against Mycoplasma. So the management is also different. Here you have to go for protein synthesis inhibitors or other drugs having a different mechanism of action other than cell wall synthesis inhibition. So these are the major atypicalities which you can expect. So coming to investigations, cold agglutination test, that is non-specific. When you have a Mycoplasma infection, there will be formation of autoantibodies which will be targeting the carbohydrate antigens on your RBC membrane. So it's non-specific. That type of autoantibodies you can get in many viral infections also. And another thing is that it's not that sensitive also. Only 50% of the children with Mycoplasma pneumonia will be showing a cold agglutination test positivity. So that can be used as a screening test, which we are not doing it now. Another test is serology. Serology, IgM antibodies are not that reliable for making a diagnosis because they usually become positive by the second week and they can persist for up to 1 year. So if the child has contracted some Mycoplasma pneumonia during the past 1 year, the child can have an IgM positivity. Now, so you can have a false positive interpretation. The disease now may not be caused by Mycoplasma, but you will be considering a Mycoplasma infection. So more reliable than IgM is your IgG, but you have to wait till 2 to 4 weeks. So if the IgG titer during the acute phase and the convalescent phase, if there is a 4-fold increase in your IgG titer, that is diagnostic of Mycoplasma infection. Then culture also we are not using it now, Mycoplasma is a slow-growing organism having some specific requirements of culture. Usually takes around 3 to 4 weeks. So you cannot manage the child properly because it's a slow-growing organism, and you typically get the fried egg colonies on culture. So the test we prefer now is usually the molecular test, the PCR, from a nasopharyngeal specimen. So that is having a good sensitivity, but you should keep in mind that Mycoplasma can remain in your nasopharynx for a prolonged period of time after you contract a Mycoplasma infection. And also rarely, maybe in 25% of children, Mycoplasma is reported to be a normal nasopharyngeal organism. So you should be very cautious even when you are analyzing a molecular test. So management, as we discussed, it's primarily the macrolides. We usually use azithromycin for 5 days. If you are using clarithromycin or erythromycin, it should be a 7 to 10 days course. If the patient is resistant, that is, if the patient is having fever after 48 hours, you can change it over to doxycycline. You should give a prolonged course of 7 to 10 days. And after that, you wait for 48 hours. Still, if the child is febrile, you can go for fluoroquinolones. And any Mycoplasma infection still febrile after 7 days of infection, 7 days of starting in illness, you call it as a resistant Mycoplasma infection, where you can try your immunomodulators such as steroids, IVIG. And also, if the patient is having some predominant extrapulmonary manifestations, mainly hemolytic anemia, you can go for immunomodulation. So we'll go to the second question. Sheetal can answer this question. Thank you, Manu. So Sheetal can answer this question. A 4-year-old well-looking male child presented to the OPD with wet cough of more than 4 weeks without any other constitutional symptoms. He has a postural exacerbation of cough. Auscultation was inconclusive except for some scattered conducted sounds. Physical examination was otherwise normal. Investigations ruled out TB and foreign body. Blood examination and chest X-ray were normal. What is the diagnosis? How can you manage the child? What complications can occur if the child is not properly treated? So Sheetal, you can take some time, and after that you can start answering.
Hello, sir.
Yes,
I'm audible. Okay, sir. Sir, the diagnosis may be protracted bacterial bronchitis.
Oh, good. Okay, protracted bacterial bronchitis.
Bronchitis. Usually, we manage this child with 2 weeks of antibiotics. That is usually Mosclav.
Okay.
If we not treating the patient properly, the patient can go to bronchiectasis or chronic lung disease.
Okay, Sheetal, very good. Okay, thank you. So now I would like to sensitize you to a condition which is not commonly being considered in the differential diagnosis of chronic cough. Especially if the child is presenting with a chronic wet cough of more than 4 weeks duration, you should consider PBB, that is protracted bacterial bronchitis, in your differential diagnosis. This condition usually goes underdiagnosed, but you should try to make a diagnosis of protracted bacterial bronchitis in every case presenting with a productive cough of more than 4 weeks duration, which is not responding to your 3 to 5 days course of antibiotics, which is usually recommended for the lower respiratory tract infection. So the answer is protracted bacterial bronchitis. It's predominantly a diagnosis of exclusion. We usually consider TB, asthma, and all when you are having a slow resolution of symptoms following a chronic respiratory infection. So unlike asthma, here you get a chronic wet cough. In asthma, you usually get a dry cough. And in asthma, you will be having a child, will be a bit older child, more than 5 years usually. Here, the predominant age group is a preschooler, having a wet cough of more than 4 weeks. And unlike in asthma, here there will be no diurnal variation of cough. In asthma, you predominantly get a nocturnal cough and early morning cough. Here you get cough throughout the day and night. And also there will be some postural variation of cough. In protracted bacterial bronchitis, your bronchi will be colonized by some organisms. So there are certain conditions which predispose the child to develop protracted bacterial bronchitis, maybe some tracheomalacia, some ciliary dyskinesias, some tracheomalacias and all. In all those conditions, your bacteria clearing mechanisms, your secretion clearing mechanism may not be proper. So the bacteria will be sticking onto those areas. There will be a much more bacterial load than you expect. And the bacteria forms a biofilm and produce a persistent infections. In such conditions, there will be plenty of inflammatory mediators released and the sputum will also be comparatively more. So when there are more sputum, when you lie in one position for some time and immediately you change your posture, those sputum can flow down and irritate your cough receptors and you will be having an exacerbation of cough. So when the child is lying in the same position for some time, the child will be comfortable. Immediately when the child changes position, due to this plenty of sputum, the sputum may flow down or flow through the airway, irritate your cough receptors, and there will be a postural variation in your cough. So protracted bacterial bronchitis is mainly a diagnosis of exclusion after ruling out tuberculosis, after ruling out bronchial asthma, a foreign body and all. That's mainly a diagnosis of exclusion. But when there are facilities to make a definitive diagnosis, you should definitely try for that. So when there are facilities for doing a bronchoscopy, you can acquire bronchoalveolar lavage, and if you examine it, if you go for a microscopy, you can definitely make a diagnosis of a microbiological diagnosis of protracted bacterial bronchitis. In the BAL specimen, if you are seeing more than 10 raised to 4 colony forming units of a single organism, that is having a good sensitivity for the diagnosis of protracted bacterial bronchitis in a child having a wet cough of more than 4 weeks. Retrospectively, when you analyze, the child should become better after a prolonged course of antibiotic. We usually give antibiotics in a typical respiratory infection for 5 to 7 days, maybe 3 to 5 days also sometimes. But here the child needs a prolonged antibiotic course because there is significant biofilm formation in your trachea and bronchi. So it should be a 2 to 4 weeks of antibiotics. So unlike in LRTA, here the predominant organisms that colonize your trachea and bronchus are mainly some H influenza, non-typable H influenza, Staph aureus. Then there can be Moraxella catarrhalis. So all these organisms are not universally sensitive to your amoxicillin. So here the first line therapy should be a combination of amoxicillin and clavulanic acid. So amoxiclav is your first line therapy that you have to give for 2 to 4 weeks. So management is antibiotics, but it should be amoxiclav as a first line drug because the organisms are usually resistant to plain amoxicillin alone plus physiotherapy. If the child is allergic to amoxicillin, you can consider amoxiclav. You can consider Septran, azithromycin, or some third generation cephalosporin. So we'll go to the last question of this discussion. So MS, if MS is there, she can answer this question. MS, are you there?
Yes, sir.
Okay, a 5-year-old child is referred to our OPD with history of chronic dry cough of 8 weeks duration. The child also complains of occasional dyspnea on exertion. Mother gives a history of on and off joint pains and swelling of bilateral knee joint and ankle joint. There is no family history of asthma and his TB workup is negative. On examination, the child looks emaciated. Clubbing is present. The child is having tachypnea with minimal retractions. And SpO2 shows only 93% of saturation in room air. And on auscultation, you can hear fine, mid and late inspiratory, fine crepitations. So the questions are, okay, I will also be showing the CT scan. CT scan, you can, I don't know whether it's very clear. You can see some ground glass opacities, especially towards the posterior aspect, basal zone. Also, you can see the thickened interstitium and some cystic lesions in and around. Bilateral findings are there. You can see some cystic lesions also. So this is the ground glass opacities towards the posterior aspect on this right side. So MS, what's the diagnosis and what investigations you can confirm your diagnosis and how will you manage it?
Sir, can you show the first slide again?
Okay.
Sir, since the cough is of dry cough and it is more than 8 weeks, more than 6 weeks duration, and also the child is emaciated with clubbing with tachypnea, it could be a cystic fibrosis. One possibility is cystic fibrosis more than 6 weeks.
Okay. So in cystic fibrosis, there will be some other clues you will be given during the in your history. So right from the newborn period, you may be getting some clues. There can be some cystic fibrosis patient usually presents with a productive cough. Usually they will be having plenty of secretions, thick secretions. So they will be predominantly having a productive cough. But here the child is typically having a dry cough, and the child has desaturated also. So you can definitely consider cystic fibrosis is a good differential diagnosis. But here I would like to entertain some other diagnosis, which usually goes underdiagnosed, and we may not be considering it in our differential diagnosis. Okay, I agree that it's not that common as your bronchial asthma or tuberculosis. Still, you have to consider interstitial lung disease in your differential diagnosis. So here the answer is interstitial lung disease, which you should consider. It's not that uncommon in children. You can diagnose it if there are facilities are available. Okay, thank you, MS. It's a close differential diagnosis. You can consider cystic fibrosis. It's a very good differential diagnosis, but here we will discuss interstitial lung disease. After having a typical HRCT finding, I would like to entertain interstitial lung disease as the first diagnosis.
Okay, sir.
Okay. Interstitial lung disease. This is the interstitial. You have the alveolus, you have the capillary, and between the alveolus and capillary, you have a one cell thick space through which the air exchange takes place. So some infections or inflammations predominantly affects that area, and that is referred to as the interstitial lung disease. And also you should keep in mind that though the term is interstitial lung disease, always there will be some form of inflammation in the capillaries as well as in the alveoli and the distal air sacs. So since the inflammation is not confined to interstitium alone, the preferred terminology nowadays is a diffuse lung disease. But in this discussion, we will be coining the term interstitial lung disease, but the correct terminology used now is a diffuse lung disease, since the capillaries as well as the alveoli and the distal airways are also involved. So here the child is having some connective tissue disorders also. The child is having a history of arthritis, and on that background also interstitial lung disease is having a higher priority than your cystic fibrosis.
Okay.
So interstitial lung disease is usually having a bad prognosis. They are having a very high morbidity and mortality, and usually it's underdiagnosed because we are not considering it in our differential diagnosis, and also we are having limitations in making a proper diagnosis of interstitial lung disease. So considering the interstitial lung disease, predominantly we consider two age groups. Interstitial lung disease confined to infancy. So there the etiology is entirely different. There you can consider some genetic conditions, especially related to the surfactant proteins in your differential diagnosis. There the genetic studies are having an upper hand rather than your HRCT or your other investigation. So one group of disorders are confined to the infancy alone. There you should consider interstitial lung disease with an entirely different etiology, mainly surfactant protein deficiencies along lung growth disorders and all. So beyond infancy, you can consider a major group of interstitial lung disease having an entirely different etiology, which may be associated with your connective tissue disorders, which may be connected with your infections such as HIV, hypersensitivity pneumonitis after when you are having a persistent bird exposure. It may be drug induced, it may be radiation induced interstitial fibrosis post radiation for malignancy and all. Okay. So how will you make a diagnosis? So diagnosis is predominantly, you should take a proper history to consider any history of exposure to birds and all. After proper history is the mainstay, then you can consider a pulmonary function testing where the forced vital capacity will be reduced. So it's not that useful, or you will not get any clue to specific interstitial lung disease, but you can have a baseline assessment of your forced vital capacity, and you can keep that for further following up the child or prognosis or the response to treatment. When facilities are available, you can also go for a diffusion capacity for carbon monoxide, which will be typically reduced since the interstitium is affected. So the investigation we rely now is basically a high resolution CT. Actually, high resolution CT is actually only one of the proper indication where you have to consider a high resolution CT in lung conditions in children. That is interstitial lung disease. In all other conditions, you can go for a plain CT and you can request for a contrast study if needed. So it's only interstitial lung disease if you are suspecting, specifically you should go for a high resolution CT, which will give you many clues, not only for the diagnosis, they will also mark some areas. You can also get some areas for considering a liver biopsy. So that is a preferred investigation. In a high resolution CT, you will get many clues for a specific interstitial lung disease as well as interstitial lung disease in general, such as ground glass opacities, mosaic pattern, thickened interstitium, cystic lesions in and around. And also you can get some pattern identification, which may point to a definitive etiology. If you are considering in HIV patients following lymphocytic interstitial pneumonia, you get a specific pattern on HRCT, which is diagnostic. So you can get some diagnostic clues as well as some non-specific clues for interstitial lung disease from your HRCT. So when facilities are available, you should go for bronchoscopy and BAL. From there, you get many vital clues. BAL can be considered as a liquid biopsy. There from BAL, you get many vital clues. We'll be discussing in the next slide some important BAL findings. So when facilities are available, you should also go for a video-assisted thoracoscopic lung biopsy also. Lung biopsy is considered as the gold standard investigations to diagnose interstitial lung disease. Last few slides. Management is primarily supportive management. You can, if there is any primary condition identify, you manage the case. If the child is desaturating, you supplement the child with oxygen. He may need a home oxygen also because desaturation can be very early in interstitial lung disease. Then the mainstay is immunomodulation. You have to consider it early so that fibrosis can be prevented. So early immunomodulation with steroids, hydroxychloroquine and other steroid-sparing agents. And as a last result, you can consider lung transplantation, which may not be feasible in many cases. So this is a normal BAL cytology, which you should be knowing. Around 85%, the normal BAL cytology is alveolar macrophages. 10 to 15% is lymphocyte. Epithelial cells are only less than 5%. Neutrophils are less than 3%, and eosinophils are very, very minimal. In the interstitial lung disease, if the lymphocytes are increased, typically it's a hypersensitivity pneumonitis. If the child is having exposure to pets, birds, and all. Here, the CD4 CD8 ratio is typically less than 1. In normal BAL, the CD4 CD8 ratio should be more than 1 if you can have facilities for doing a flow cytometry with your BAL specimen. Predominantly, you'll be told that the neutrophils are usually less than 3 to 5%, but if the neutrophils are increased, you can consider ILDs in general, and specificity for idiopathic pulmonary fibrosis is very high. Then eosinophils, if they are increased, you can consider LCH, and in BAL flow cytometry, there will be predominance of CD1A positive cells. Lipid-laden macrophages, you can consider some chronic aspiration syndromes, especially in a cerebral palsy child and all, going for an interstitial fibrosis and inflammation. So in your gastric aspirate, there will be plenty of lipids, and lipid-laden alveolar macrophages are specific for aspiration syndrome. And hemosiderin-laden alveolar macrophages is seen in pulmonary hemorrhage, which may be due to your good pasture syndrome and your cow's milk protein allergy and all. So if the bile is grossly milky, you can consider alveolar proteinosis without any microscopy. If the bile is milky, you can consider this alveolar proteinosis as a major diagnosis. And sarcoidosis is rarely seen in children. It's usually seen in adults. There will be predominance of CD4 cells in your flow cytometry. So I would like to sensitize you to all these three conditions. You should keep in your mind. These conditions are not that rare. If you have facilities, if you have facilities for making a definitive diagnosis, if you could just consider it in your differential diagnosis, you could refer the child to hospitals where there are facilities for making a definitive diagnosis. So all these conditions, if you miss the diagnosis or if you make your diagnosis, if you delay the diagnosis, it definitely affect the prognosis of the conditions in either in protracted bacterial bronchitis or in interstitial lung disease, or in the case which we have discussed earlier. If you are not able to make an early diagnosis, definitely the prognosis of the condition is going to be bad. So thank you. Thank you all. If you're having any doubts, you can ask. I think I have taken a bit longer time, and sorry for that.
Dr. Mohandas ഉണ്ട് അവിടെ ദാസ്.
Hello, sir.
Thus, we can go up to 9 o'clock.
Okay, okay.
Sure, no problem.
It is a thoroughly enjoyed the show, Dr. Bindusha and Chinchilu. It is wonderful because all these years since we started this PG forum, the respiratory cases discussion were very few cases, and all those this thing shortages now compensated by these discussions covering the excellent way. Both of you did very well, and that is a learning session for me too. The just because of the PGs are there, very interesting to see, heartening to see the number of PGs also has come up. YouTube also they are watching. And the few comments may not be related to this thing. Regarding the second case of this Mycoplasma scenario, we were discussing the atypical presentations of Mycoplasma in the present context. The atypicality of the extrapulmonary manifestations are little less in during this Mycoplasma season. And atypical situations, other than the commonest one, of course, is the Mycoplasma. Next one is the rickettsials. And rarely we need to consider Legionella, leptospirosis, ornithosis, and other bird-borne situations also. The few extra lung clinical manifestations are the clues for this thing. Chinchilu was pointing out the loose stools and the other system involvement pointing towards the viral. When you're getting a loose stool, Legionella is one of the clues. In a Legionella, point is many of them will be producing conjunctival congestion and the muscle tenderness. Mycoplasma will produce, leptospirosis will produce, and the Legionella also will produce. The aseptic meningitis type of drowsiness will be the more in case of Legionella, and diarrhea also. So the clinical context in which you are getting this situation, the extra lung manifestations and the investigations are the clue. The Legionella is a rare entity, but you need to consider. The chlamydia also, but the chlamydia is in the younger age group, below 1 year. But if it is occurring in older age group, the sticky eyes are helpful. And the investigations wise, the rickettsia, Mycoplasma, all will be normal. A little bit of eosinophilia in a case of Mycoplasma is helpful in the present context. And the hyponatremia is one thing which can be a clue for the Legionella. Like that, you may make use of the clinical context and the epidemiological aspects and the other system involvement in a case with atypicality, especially the rash. The rash gives a clue towards atypicality, but in this present context, there were many cases without the extrapulmonary manifestations. That is just a comment for the postgraduates. Other experts can add on to this.
Hello. Can you hear me?
Sir.
Bindusha and Dr. Chinchilu, it was a very, very entertaining session. All the scenarios you have described were really informative, even for consultants, not only for PGs. I want to congratulate you both, and also the other organizers from TRIVANDRUM unit. Thank you.
Chinchilu, one doubt regarding the last case scenario. When you are getting an interstitial thing, will the 6 minutes walking time and saturation fall will be helpful? Are you using that in the pediatric age group?
Sir, actually, we are not seeing cases of interstitial lung disease. I think, Bindusha madam.
So we can use that, especially whenever there is a restricted lung disease. ILD is a type of restricted lung disease. In all those conditions, actually there will be desaturation in 6-minute walking test. 6-minute walking test can be used as, it's not actually non-specific. In any condition where there is some restriction to the lungs, there will be patient can have this desaturation during 6-minute.
In the departments where we are following the pulmonology cases, more of the pulmonology clinics we are running, what is the lung injury outcome during the COVID season? We would like to know, because in certain states there were many cases of pediatric multi-inflammatory syndrome, and atypical lung involvement were all there. In Kerala, it was not much. So, what is the consequence and the outcome of this thing in the lung, for the lung in a case of pediatric age group? Of course, there are the clinics of the COVID situations in adults. There are many problems. So, are we having an outcome like that, interstitial or anything for the pediatric age group? That also interesting.
Sir, actually, we are not following up them properly, but what we are seeing in the respiratory clinic is that after COVID, we are seeing more number of cases where we have difficult to control asthma. Before that, we did not have so much cases which were not responding to your even step 3 management. Nowadays, we do see cases which are a little more difficult to control. Other than that, we are actually not doing any further studies as of now. That is just from my personal experience.
We were having in pediatric age group during this HIV period in the 90s and early 2000, before the heart started in 2004. At that time in Trichur, there were many cases of pediatric HIV. And during those period, we were getting LIP, PCP and all. And not many survivors are there. We are having survivors. Dr. Ladika was in charge, and we are having adults getting married and children all. Any more people, expert comments? Otherwise,
hello,
I'm
Kalpana.
Kalpana,
I enjoyed the discussion because I'm not into respiratory system cases nowadays, but this was very nice, and it was a brushing up of my previous memories also. And we have actually a child with severe SLE with exactly similar picture as that is Chinchilu has shown, with ground glass opacities, and that a child has neurological manifestation as well as cardio, this renal manifestation and extensive skin lesions. Child stopped all the drugs and now came in a very moribund state, and child is recovering slowly. So there are cases, we may not be seeing all these multi-system cases, but they are definitely rare. And I just want to add the habit cough also, which is very, very, very common. And when all the investigation, everything is coming, the last PG Club, I think Dr. Amdekar has mentioned about that, because the cough that is absent in sleep, and it is always present in the other times. And when you are examining, it will be completely present. So that habit cough, you can just take a history and you can make the diagnosis. So I have seen patients coming to me after extensive investigations, and then only the diagnosis is made. That is a very, very, very important case and very common case also. And regarding the OSCE thing, it is very nice and well described, but I think it can be a few more cases can be discussed in a little more faster will be better. That is my personal opinion. Maybe PGs may find it more, maybe finding it otherwise, but a little more faster, and the questions and the PGs can be asked to answer in the chat box itself, so that they will be very happy. That is what we are seeing when we are doing the OSCE in Calicut. What we are seeing is like that. When they are writing, they will be very, very interactive and very happy. And another thing is, we can ask PGs from other institutions to answer. That will be more. In our neuro discussions, mainly what we do is, the OSCE will be from one center, the discussion will be from another center, and sometimes another person, another expert may be discussing on that, like that. So if it is like that, the involvement may be different, but this is also very good. What I'm telling is some ways to improve. And the questions can be posted, and immediately after that they will be writing, and then you can ask one person to answer. Thank you for a very excellent discussion. I enjoyed actually. Thank you.
Actually, madam, they were writing. A lot of people responded to the question. I was
But
seeing the answers.
when they are
They
writing
were
in the main
yeah.
chat box, they
Yeah,
actually
yeah, they
other
make
they also are
encouragement
enjoying
also.
actually.
Okay.
Okay.
That's why we can wind up, man.
Is there anyone there? Anyone to say vote of thanks? Otherwise, we can wind up.
Sure.
I'm here.
Okay, ma'am. So
Dr. Lakshmi is there. Okay, tell.
I would like to thank Bindusha madam and Chinchilu sir for the excellent conduction of the OSCE. And also I would like to thank all the PGs who have taken part actively. I would also like to thank Purushothaman sir for all his valuable insights and all the discussion towards the end. Also, I would like to thank Mohandas sir, Priya Srinivasan madam, IAP PG Club office bearers. Also, IAP State Office Bearers, Dr. Riyaz sir and also Gobi Mohan sir. IAP Trivandrum Office Bearers, Kalpana madam and Srijit sir, and all the faculty as well as all the postgraduates who have taken part. Thank you so much, everyone. This was a first experience to us also, so we would like we will consider and we will all we are welcoming all the suggestions and we will implement it in the future. Thank you, everyone.
Good night. Bye.
And please register for the pedicon also, sir, as early as possible. As it's a humble request from to all the members here.
Okay.
And the postgraduates also will give the gifts.
Kalpana. ഞാൻ രജിസ്റ്റർ ചെയ്തായിട്ട് പ്രഖ്യാപിക്കുന്നു.
Thank you, sir. Thank you so much, sir.
Okay. 5000 ഉറുപ്പ അല്ലേ?
Sir, അതെ.
Okay, തരാം. അയക്കാം. Okay, good night. Bye.
എന്താണ് 5000.
Okay.
Srijit.
Yes, sir. We can close the meeting.
Okay, bye.
Thank you. Thank you all. Thank you, sir. Thank you, sir.
Say the vote of thanks, one word. Okay, we can conclude. Okay.